So today we'll talk about the third part of stroke localization, in which we'll discuss about the brainstem syndromes. So first of all, we'll take up midbrain syndrome. So first of all, we need to know about the anatomy of midbrain. These are the superior cerebellar peduncles, periaqueductal gray matter, these are the oculomotor nerve nuclei, superior colliculus, red nuclei, substantia nigra, and these are the cerebral peduncle consisting of descending corticospinal and corticonuclear fibers. By label, so these are the cerebral peduncle. This is red nucleus. This is superior cerebellar peduncle. Superior colliculus. And if I draw the oculomotor nerve, so here it originates and it courses down. So this is oculomotor nerve. Now we'll discuss syndromes related to midbrain. So first is Weber syndrome. So Weber syndrome occurs when there is an injury in the region of medial cerebral peduncle. So when injury occurs in the area of medial cerebral peduncle, so the fascicles of oculomotor nerve are affected. Apart from that, the descending corticospinal fibers are affected. So that results in ipsilateral third nerve palsy and contralateral hemiplegia. So if there is an injury here, so what will happen? Ipsilateral third nerve palsy plus contralateral hemiplegia. Clear? Now we'll talk about the next syndrome, that is Benedict syndrome. Benedict syndrome occurs when there is an injury in the region of red nucleus. So if there is an injury in the region of red nucleus, somewhere here, so red nucleus is affected. Apart from that, the fascicles of third nerve are affected. Due to involvement of red nucleus, there occurs contralateral intention tremor, hemichoria, and hemiathetosis. And due to involvement of fascicles of third nerve, there occurs ipsilateral third nerve palsy. Now let me tell you, when we talk about the intention tremor due to injury to red nucleus, so they are very classical. If we ask the patient to keep his hands like this, he is not able to maintain this posture. So this type of tremor is known as rubral tremor or wing beating tremor. They are classical of red nucleus injury. Apart from this, this wing beating tremor can also be seen in Wilson's disease. So, if I mention this intention tremor is known as wing beating tremor or rubral tremor. Also seen in Wilson's disease. Now, we'll talk about the next syndrome, that is Knoth-Naegel syndrome. Knoth-Naegel syndrome occurs when there is an injury to the superior cerebellar peduncle. So if there is an injury somewhere here, which apart from superior cerebellar peduncle also involves the oculomotor nerve, so then the Knoth-Naegel syndrome occurs. Superior cerebellar peduncle. So what would be the effects? There will be ipsilateral third nerve palsy, and contralateral ataxia. Another syndrome we'll talk about, that is Claude syndrome. So let me tell you, C for Claude, C for combination. So it is a combination of Benedict and Knoth-Naegel syndrome. So C for Claude, C for combination. So it's a combination of Benedict and Knoth-Naegel syndrome. That means there occurs injury to both red nucleus as well as the superior cerebral peduncle. So the complex symptoms of Benedict and Knoth-Naegel syndrome occurs. Now last but not the least is the Perinaut syndrome. So Perinaut syndrome occurs when there is an injury to the dorsal midbrain in the region of superior colliculus. When superior colliculus or dorsal midbrain injury occurs, so what would be the effects? So it will result in upward gaze paresis. There is a difficulty in upward gaze. Apart from that, there is impaired convergence, and on attempt to upward gaze, there occurs convergence retraction nystagmus. Convergence retraction nystagmus. It is very classical of this condition. When you attempt to do the upward gaze, there occurs convergence and also the retraction of eyeball. That is known as convergence retraction nystagmus. Apart from that, there occurs lid retraction, which is known as Collier's sign. Collier's sign. And because the pretectal nucleus is in close proximity to the superior colliculus, there is light near dissociation. Light reflex is absent. Now the classical cause of this Perinaut syndrome is compression. Compression due to pineal gland tumor. If I talk here, the cause is pineal gland tumor. There could be the other causes also of dorsal midbrain injury, like infarct, like hemorrhage, like tumor, like trauma. But this is the most important cause, pineal gland tumor, and also obstructive hydrocephalus. So this is all about the syndromes related to midbrains. If I summarize, Weber syndrome occurs when there is an injury to the area of medial cerebral peduncle. So there occurs ipsilateral third nerve palsy and contralateral hemiplegia due to involvement of cerebral peduncle. Benedict syndrome occurs when there is an injury in the area of red nucleus. So because of involvement of red nucleus, there is contralateral intention tremor, there is hemichoria, hemiathetosis, and ipsilateral third nerve palsy. Knock-Nagel syndrome when there is an injury to superior cerebral peduncle. So there occurs ipsilateral third nerve palsy and contralateral ataxia. Claude is a combination of Benedict and Knock-Nagel syndrome because there is an injury to both red nucleus and superior cerebellar peduncle. And Perinaud syndrome occurs when there is an injury in the dorsal midbrain region. So this is Perinaud syndrome, in which there is classically upward gaze paresis, impaired convergence retraction nystagmus, lid retraction, which is called as Collier's sign, and also light near dissociation. That means light reflex is absent, but accommodation reflex is present. This is all about the midbrain syndromes. Now we will talk about the Pontine syndromes. Now let's talk about the Pontine syndromes. We need to know about the anatomy of Pons for that. So these are the longitudinal bundles of descending corticospinal and corticonuclear fibers. These are the pontine nuclei and these are the pontocerebral fibers. This is middle cerebral peduncle. This is nuclei of sixth nerve and this is nuclei of seventh nerve. This is seventh nerve and these are the sixth nerve. This is trapezoid body here. This is medial lemniscus. This is spinal nucleus and tract of trigeminal nerve. This is vestibular nucleus and cochlear nucleus. So we'll talk about the important structures here. This is sixth nerve. This is seventh nerve, facial nerve, fascicles. This is sixth nerve, abducent nerve. This is the nucleus of seventh nerve and this is the nucleus of sixth nerve. This is medial lemniscus. And these are the bundles of corticospinal and corticonuclear fibers. So there are two important syndromes when we talk about the Pons to name. First one is Millet-Gubler syndrome. So Millet-Gubler syndrome occurs when there is an injury to the ventral pons, ventral pontine injury. That means if there occurs injury in this region, so this is responsible for Millet-Gubler syndrome. Now what are the components of Millet-Gubler syndrome? Millet-Gubler syndrome, it consists of facial nerve fascicles, it consists of the abducent nerve fascicles. Apart from that, it contains the descending corticospinal fibers. So the effects are lateral rectus palsy of ipsilateral side. ipsilateral lateral rectus palsy due to involvement of sixth nerve fascicles. There is ipsilateral facial palsy and there is contralateral hemiplegia. So that is all about Miller-Gubler syndrome. Another important syndrome is Foville syndrome. It occurs when there is inferior dorsal pontine injury. So when there is inferior dorsal pontine injury, that means there is an injury so this one is the area of Foville syndrome. Now let me tell you very important thing. Here look at the structures which are involved. Here there is an involvement of again the sixth nerve nucleus, the seventh nerve nucleus, sixth nerve fascicles and the bundles of descending corticospinal fibers. Now very important thing I want to tell you here is here because the nucleus of sixth nerve is involved, so the effect is different from that of the involvement of fascicles. Okay. Now let me the abducent nucleus. If I talk about this is an abducent nucleus. Okay, sixth nerve nucleus. So this nucleus contains interneurons. It contains interneurons which transfers fibers to contralateral oculomotor nuclear complex. This is third nerve nuclear complex. Now this third nerve nuclear complex, there is subnucleus for each of the extraocular muscle it supplies to. Say inferior rectors, medial rectors, okay, levator palpebrae superioris. So there is a subnucleus for each one of them. Now these interneurons, let me tell you, supposingly this is the midline. So these the interneurons in sixth nerve nucleus, it transfers fibers through medial longitudinal fasciculars to the medial rectus subnucleus. Okay. Now I will tell you what is the importance of this. Supposingly if I want a patient to look at in this direction, okay, and if abducent nerve is affected on this side, so there the patient will not be able to look on this side. I mean that means there will be impaired abduction of this eye but preserved adduction of this eye. Okay, there is no problem with this eye, there is only problem with the lateral gaze, with the abduction of affected side. Okay, but if there is an involvement of nucleus, so not only there is impaired abduction of the affected side, but there is also impaired adduction of the contralateral side, because these interneurons which transfer fibers to the medial rectus subnucleus of contralateral side are also affected. Okay, so not only there will be difficulty in abduction of this side but also adduction of this side. So that's why there occurs lateral gaze palsy rather than lateral rectus palsy. This is important. I hope I can make it clear. So there is lateral gaze palsy. This is important. Here there is lateral rectus palsy. Okay. Apart from that, again there is ipsilateral facial palsy. and there is contralateral hemiplegia. Now, because this is, I've told you this one is medial lemniscus. This structure is medial longitudinal fasciculus. So MLF can also be affected, and medial lemniscus, due to involvement of medial lemniscus in this. Medial lemniscus is paired in Miller-Gubler syndrome. Due to involvement of medial lemniscus in this, so there would be contralateral loss of proprioception and vibration sense. So medial lemniscus and MLF can be affected. Due to involvement of medial longitudinal fasciculus, again there will be INO. So this is all about the Fovile syndrome. There is another variant of this Fovile syndrome, a superior dorsal pontine injury, which is called as Raymond-Seston syndrome. In Raymond-Seston syndrome, it is similar to Millett-Gubler syndrome, but the facial palsy does not occur. So there is only lateral rectus palsy and contralateral hemiplegia, but these are two important syndromes. So I'll end my discussion here only. So this is all about the Pontine syndrome. Important point which you have to remember is Millett-Gubler and Fovile are essentially same. Only difference is in Millett-Gubler there is lateral rectus palsy. That means there will be impaired abduction on the affected side. But in Fovile syndrome there is lateral gaze palsy. There is impaired abduction of affected side and impaired adduction of contralateral side. That is all about the Pontine syndromes. Now we will talk about the medullary syndromes. So now we'll talk about the medullary syndromes. So first we'll discuss the anatomy of medulla. This is the pyramid and the arcuate nuclei. I'll make the rest of this will have another color. This is restiform body of inferior cerebral peduncle. Inferior cerebellar peduncle. This is the vestibular nuclei. This is dorsal nucleus of vagus. This is nucleus tractus solitarius. This is nucleus ambiguous. So let me tell you, each one of them is important. There is spinal nucleus and tract of trigeminal nerve. There is dorsal spinocerebral tract, ventral spinocerebral tract. There is lateral spinothalamic tract. There is descending hypothalamic fibers. There is hypoglossal nuclei. This is hypoglossal nerve. There is medial lemniscus. This is inferior olivary nucleus. So I've tried to make it as simple as I can. Now if I label, this is hypoglossal nerve. This is pyramids which contain corticospinal tracts. This is arcuate nuclei. This is medial lemniscus. This is dorsal and ventral spinocerebral tracts. Dorsal and ventral spinocerebellar tracts. This is lateral spinothalamic tract. This is descending hypothalamic fibers. This is spinal nucleus and tract of trigeminal nerve. This is inferior cerebellar peduncle. This is vestibular nuclei. This is dorsal nucleus of vagus. Nucleus tractus solitarius and nucleus ambiguus. So I hope everything is clear. I'll repeat once again. This is pyramid, arcade nuclei. This is medial lemniscus. This is hypoglossal nerve nuclei and fibers. This is dorsal and ventral spinocerebellar tract, nucleus tractus solitarius, nucleus ambiguus, and dorsal nucleus of vagus. These combine to form the 10th nerve. This is spinal nucleus and tract of trigeminal nerve, vestibular nucleus, inferior cerebral peduncle. Each one of them is important to understand the medullary syndromes. So first of all, we'll talk about the medial medullary syndrome, or which is also called as Dejeron's anterior bulbar syndrome. So what all are affected in this syndrome? It includes this part. So primarily it includes the hypoglossal nerve, medial lemniscus and pyramids. So the consequences are ipsilateral weakness and atrophy of tongue due to involvement of hypoglossal nerve, due to involvement of this pyramids, there is contralateral hemiplegia, but mind you, sparing face, because the fibers for face, they give away from the pons. So this is because of pyramids involvement. And because of the involvement of medial lemniscus, there is contralateral position and vibration sense lost. Medial lemniscus. So this is all about the medial medullary syndrome. It's quite simple, but when we'll talk about the lateral medullary syndrome, so it is a bit complex. Let's talk about now the lateral medullary syndrome, or which is also called as Wallenberg syndrome. Very often asked question, Wallenberg syndrome. Most commonly it is due to vertebral artery occlusion followed by posterior inferior cerebral artery occlusion. vertebral artery followed by posterior inferior cerebellar artery occlusion. Now it is because of the involvement of these. This one is the lateral medullary syndrome. Okay. Now what would be the impact of this? We'll discuss each one of them. Now due to involvement of inferior cerebellar peduncle, there is ipsilateral ataxia. Also because of the ventral and dorsal spinocerebellar tracts, there is ipsilateral ataxia. The patient will fall to the side of the lesion. Okay. And because of the involvement of this vestibular nuclei, there will be vertigo, diplopia, nystagmus, giddiness, nausea, vomiting. These would be the results. Now, because of the involvement of nucleus tractus solitarius, which is mainly responsible for taste. Okay, so what would be the effect? Because of the involvement of nucleus tractus solitarius, which is primarily concerned with taste sensation, there will be ipsilateral loss of taste sensation. And because of the involvement of nucleus ambiguous and also the dorsal nucleus of vagus, due to involvement of dorsal nucleus of vagus and nucleus ambiguous, there would be ipsilateral dysphagia, dysarthria, hoarseness because of the palsy of vocal cords and pharyngeal muscles, dysphagia, hoarseness, dysarthria. And because of the involvement of spinal nucleus and tract of trigeminal nerve, there is ipsilateral loss of pain and temperature sensation over the face. And finally, because of the involvement of this descending hypothalamic tract, there will be ipsilateral Horner syndrome. There is ipsilateral Horner syndrome. Now, all of these things which I have discussed so far, they occurs on the ipsilateral side. The only thing which occurs on the contralateral side is, sorry, but there is a lack of space. The only thing which occurs on the contralateral side is due to involvement of this lateral spinothalamic tract. So due to involvement of lateral spinothalamic tract, there will be contralateral loss of pain and temperature. So ever you come across a patient who has this kind of crossed sensory loss, okay, if patient is having loss of pain and temperature over face on one side, on our rest of the body on the other side, think of medullary syndrome. And if you come across a patient who has crossed motor weakness, like he has facial weakness on one side and contralateral body weakness, so you should think of Pontine syndrome, right? So this is all about the brainstem syndrome, particularly the medullary syndrome. If I talk about the lateral medullary syndrome, once again, because it's an important topic, or Wellenberg syndrome, so primarily the cause is vertebral artery occlusion followed by posterior inferior cerebral artery occlusion. All of the changes, they occur on the ipsilateral side. Only thing which occurs on contralateral side due to involvement of lateral spinothalamic tract is pain and temperature loss. And on ipsilateral side, due to involvement of inferior cerebral peduncle, there is ipsilateral ataxia due to vestibular nuclear, giddiness, nystagmus, vertigo due to involvement of spinal nucleus and tract of trigeminal nerve. There is ipsilateral pain and temperature loss over face due to involvement of dorsal nucleus of vagus and nucleus ambiguous. There is ipsilateral dysphagia, hoarseness of voice due to involvement of nucleus tractus solitarius. There is ipsilateral loss of taste sensation due to involvement of descending hypothalamic fibers. There is ipsilateral Horner syndrome. So this is what happens in a case of lateral medullary syndrome. Now we will talk about the lacunar strokes.